Welcome to the Agency for Healthcare Research and Quality's webinar on digital healthcare innovations to engage and empower patients in their care. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Sheena Patel, and I will be moderating today's webinar. I currently serve as a health research scientist for AHRQ's Digital Healthcare Research, or DHR program, which is part of the Center for Evidence and Practice Improvement. AHR's mission is producing and disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients, clinicians, and health systems. We will discuss 3 of these exciting research projects today during our webinar. Next slide, please. The agenda for today's webinar is now displayed. Please note that we are recording this webinar and that the recording and slides will be available on the AHRQ Digital Healthcare Research website in a few weeks. You will be notified by email once they are available. Next slide. We are pleased to have with us today an esteemed group of presenters. They include Dr. Kimberley D, Dr. David Gustafson, and Dr. Sunit Jariwala. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Dr. Lakes and Gustafson also have no relevant financial interests to disclose. Dr. Jariwala is a principal investigator for Avis and Sont Health. Also, please note that no commercial support was received for the development of this learning activity. Next slide. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during presentations, feel free to submit questions that you have for the presenters using the question and answer Q&A panel located to the right of the PowerPoint slides. Please include the presenter's name on the presentation number, first, second, or third, with your question. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. Next slide. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to describe how wearable technology can be used to engage adolescents in managing their mental health, identify how older adults can use self-management tools to make informed healthcare decisions, and discuss the importance of involving both patients and healthcare providers in the development and implementation of mobile interventions. Next slide. And now, it is my pleasure to introduce our first presenter, Dr. Kimberley Lakes. An established clinician scientist, Dr. Lakes currently is a professor in the Department of Psychiatry and Neuroscience at the University of California, Riverside, where she directs a multifaceted research program. Dr. Lakes is interested in holistic, innovative, accessible, and culturally relevant interventions to promote psychological well-being, particularly self-regulation in children and adolescents. Her current work, supported by AHRQ, includes the development and study of digital health interventions to improve and support self-regulation in youth with ADHD. Passionate about global child health, Dr. Lakes is collaborating with scientists in South Africa, Europe, and Asia on multiple projects focused on child and adolescent well-being. In recognition of her growing global involvement, Dr. Lakes received a 2023 Fulbright Global Scholar Award. And now I would like to turn the control over to Dr. Lakes.
Thank you very much for the opportunity to be here. I'm going to talk about the project that we've been working on over the last few years and hope to continue over the next few years with children and families with ADHD. Our overall goal is to develop patient-centered digital healthcare technologies that can help promote co-regulation between children and parents in order to support timely and targeted mental health intervention for youth who are at risk for poor outcomes. I'll just mention briefly a few things about ADHD for those of you who may be less familiar with the condition. This is the most prevalent childhood psychiatric condition in the United States. Various studies estimate the prevalence in the United States at somewhere from 7 to 10%. And it's characterized by deficits in self-regulation, which I'll address more in just a minute. ADHD is also a very relevant public health problem. It has a very high annual societal cost in the United States. You can see the reference at the bottom of the slide from a recent study estimated this cost to be close to 20 billion among children and close to 14 billion among adolescents. That's the annual societal cost. ADHD core symptoms fall into two broad categories, and the first is inattention, which can lead to difficulties in areas including paying close attention to details, being able to follow through with tasks, being able to organize your tasks and your activities and responsibilities, being able to manage your time effectively, and just engaging in non-preferred tasks. In addition, many individuals with ADHD also have hyperactivity and impulsivity, and this refers to overactive, restless, fidgety behaviors and difficulty controlling impulses or tending to act out impulsively. Some individuals with ADHD will have a combination of these symptoms, and some will be more predominantly inattentive or predominantly hyperactive, impulsive. So over the last few decades, there's been a lot of wonderful research about evidence-based interventions for children with ADHD and adolescents. And these have included medication treatments and cognitive behavioral therapies and a combination of the two. And despite a lot of progress in evidence-based treatments, there remain some current treatment challenges. And one of these is the need for coordination across points of care. There are many different points of care, from school to home to maybe a clinic with a therapist, to a psychiatrist, to your pediatrician, and coordination of treatment and intervention and supports across these points of care can be a challenge. One of the reasons for this is that there are limitations in the approaches to information sharing across points of care. Rarely is it done in a very systematic way, and this can also lead to a lack of reliable and valid information, as well as delays in treatment adjustments, as sometimes that communication across various points of care can take months to actually lead to treatment adjustments. In addition, because of deficits in self-monitoring and adherence over time, it's often the case that a lot of progress will be made initially in treatment, and then a lack of adherence or consistency over time can cause problems to reemerge or new problems to emerge. And, a classic example would be in the use of behavioral therapies, which in childhood have traditionally included some sort of reward system, whether it's using a marble jar or a point chart, a behavior chart, and adhering to that, updating it, and using it consistently over months and years effectively has been a real challenge. So we looked at how we could develop potential digital solutions to address these challenges. And the first would be in focusing on adolescents who are in this transition period from childhood to becoming young adults and living independently. We want to help develop self-regulation in these adolescents, and to do that in a scaffolded process where parents are involved in helping them co-regulate while they develop and build their skills for self-regulation. Digital solutions could also address concerns about capturing reliable and valid patient data, information about activity, information about sleep quality, daily physical activity, mood regulation, and consistency in taking medications or implementing other parts of their treatment plan. We'd also like to look at how digital solutions can enhance patients' engagement in their care, and I'll say more about that in a minute, as well as to facilitate shared decision-making. Ultimately, we hope that this will improve timely and targeted intervention. So in the last few years, one of the pilot studies that we conducted focused on how we could engage parents and children, or caregivers and their children, to create goals and reinforcements and to leverage a growing technology ecosystem that would connect parents and children as well as potentially other points of care. I'm going to show you a few slides that will illustrate how we've been doing this. But first, to begin the process, we conducted participatory design workshops with stakeholders, 40 individuals in all, and these included young adolescents, parents and other caregivers, teachers and educators, and clinicians. And we used an iterative development process, and what you see in the illustration here is that in part of the children's workshops for how this intervention might look when applied digitally, they were able to sketch out and draw some design ideas for what they would see on a smartwatch. After going through this iterative development process, we conducted 2 patient deployment studies, each with 10 families. This shows an example of what might have been created for the parent smartphone application. And so in this application, on the far left, you would see parents and their children would work on creating whatever the list of daily responsibilities is. They could decide how many days a week and which days of week to assign those. These might fall into health categories like sleep or physical activity or academic, completion of homework, or other household chores. They would then also decide on the reward system and how they would implement these traditional evidence-based reward approaches for ADHD and could assign a value to each of the activities. The second screen shows you that they would then assign a value to each of the rewards and work with the children on what types of rewards were most motivating to them and what they'd like to work toward. And then they would be able to actually cash in points over time for these rewards. So a very digital application of a traditional behavior reward chart. The next screen shows the parent receipt of when a child has marked an activity as completed. This would go to the parent for confirmation and to approve that this was indeed completed, and then the rewards could be implemented. This was on the smartphone application for parents. For the youth, everything was delivered through a smartwatch. And so on the smartwatch, there was a very simple interface that the children helped to design. This had their list of what they needed to do, what they'd already done for the day, where they were in terms of earning their rewards, and then the option to add an activity of their own. So when they look at what they've done, they would click on that and go into the list, and it would show where they were for the day, as well as their rewards and points that they had earned thus far. Here's a screen that shows you what they might see if they went in to look at what they'd earned and wanted to try to cash that in for one of their chosen reinforcers. And then finally, because we're working with adolescents who we are hoping will develop independent self-regulation and be able to eventually transition away from having to the point where they have less parent involvement. We also encourage them to add their own goals and their own activities and to be able to insert those on a final screen. In addition to this, another one of the key challenges in ADHD is emotion regulation. And part of being able to develop emotion regulation is to develop the ability to self-monitor and reflect on your mood and how you're feeling at the moment, and then be able to act on it. And so using the zones of regulation, which were part of their treatment model, they would be prompted on the smartwatch to reflect on how they were feeling throughout the day, to be able to add notes, and they could add those either through writing, typing them in, or through voice input to help them begin to reflect on those. So over the course of those 2 years, this is what was developed along with the parents and the kids in this iterative process and then deployed in the home. And these are some of the key findings in that early phase of research. The first was that the children actually identified really unique benefits of using a wearable. It was more discreet. It was less stigmatizing than maybe some other type of reward system or charts that teachers and parents have used in the past. The digital technologies also demonstrated support for addressing ADHD challenges, including time and task management, and being able to follow through with treatment and health behaviors, such as, ensuring that they're getting sleep and physical activity, which are really, I think, important components of supporting self-regulation. The support of their organizational skills was also noted by parents during pandemic-related distance learning. And so interestingly, we had our first deployment study with 10 families just a couple of months after the initial March 2020 transition to distance learning. And it was noted that being able to program in and support their organizational skills, time management, was especially valuable at that time. We've also learned that systems can promote shared decision-making around behavioral targets and reward systems within families. So when caregivers were able to sit down and work with their adolescent and develop, what might be most motivating to them, to discuss what needed to be done and what was a reasonable time period to do it, when it might work, and what reasonable rewards might be, that this was seen as a really valuable process to help involve these patients in their care. In addition, one of the other key findings was that the informatics can increase awareness among adolescents and their caregivers. Awareness of many basic lifestyle activities, such as how much or how little they're sleeping, whether they're getting enough physical activity through the day, the emotion reflection that's occurring as well. These were all seen as valuable sources of feedback to patients and their caregivers. But we also learned that preferences for data visualization differ by user, and that what children wanted to see and how they interpreted data visualization that adults may be, routinely aware of in their use of digital technologies, that it was different for children, and their preferences and their ability to interpret certain types of data were different and needed to be adjusted. We also learned that interventions for ADHD need to balance self with co-regulation. And as I mentioned earlier, with the goal of being able to help adolescents transition into being more independent and less dependent on their parents to help organize their lives and make sure that their tasks are being completed. And so this is an iterative process then, where the scaffolding that the parent provides can be reduced over time to promote greater self-regulation in the youth. The data that we collected through the wearables also was valuable in promoting the opportunity to reflect, discuss, and learn from their experiences. And it was very amenable to then making adjustments through the technology based on what was learned on a regular basis. And then finally, using these digital technologies to support parent-child communication can decrease parent-child conflict. One of the key family challenges in ADHD is that the need for constant reminders and constant feedback can lead to a lot of negative interactions and negative loops between parents and children. And that being able to insert this digital intervention reduced some of that conflict, and as it also reduced the need for some of those reminders and that parent involvement. So in the current phase of the study, we're working to conduct additional participatory design and development workshops with stakeholders in the additional points of care. So we're working with educators, psychiatrists, psychologists, other mental health clinicians, and primary care physicians to begin to develop components that might address their needs and help integrate them into this ecosystem of care for youth with ADHD. Currently, we're in that development study and beginning a new deployment study with children and their systems of care. The goal is that at some point in 2024, we'll be prepared to conduct a randomized clinical trial with 60 youth with ADHD and their systems of care, And our goal is to measure key outcomes across users. And so outcomes for the child in terms of their symptoms, their perceptions of being involved in making decisions about their health care, the caregivers as well, and also addressing their needs to timely data, adherence to caregiver strategies, perceptions of shared decision-making. The providers, we want to look at whether we can provide timely, meaningful data that has an impact on the quality of care, and with educators as well to look at the use of timely, meaningful data and how that might impact educational interventions. So I'll close with some of the lessons learned that are applicable across different types of digital health intervention studies. The first is that it's really important to commit to creating usable and appealing digital health interventions as equally important to creating clinically efficacious and evidence-based tools. And so accomplishing both, taking what we know about evidence-based approaches to treatment and working on ways to make that usable and appealing and accessible requires a big commitment upfront to the resources, time, and effort to make those modifications and to do that development. The second is that digital health technologies must address needs and privacy preferences of various users. And, this is especially pertinent to what we're doing now in the new phase where we're looking at how information is shared with educators, with primary care physicians, and with mental health clinicians and providers. The next is that co-design with patients and interdisciplinary experts can lead to better and more inclusive design, but it's really important to carefully engage these groups and sometimes needing to do that separately to ensure that everyone's view is considered and that everyone's comfortable, sharing their views when they may be opposing. Designers focused on technologies to support children also need to consider the needs of the child and multiple users in the child's care network. And we know that implementing effective mental health treatment with children and adolescents is best done when their whole context is considered and other points of their life, their home, their school are considered and actually integrated into the treatment plan. Co-design using participatory design workshops can help us understand the challenges at different points of care and existing workflow. And this leads into the next point, which is that design must reduce and not add to the burden of care for caregivers, educators, and clinicians. And so in using these co-design workshops, one of our key goals is to really understand how things currently work, what the existing workflow is, and how we might reduce that burden. Because if we go in with a product or an approach that increases the burden of care, there'll be a lot more resistance to using and implementing it in the future. And then finally, interdisciplinary research agendas need to simultaneously address the needs of diverse fields across the technological and clinical sciences. This sometimes introduces challenges when it comes to publication, when it comes to clinical trial methods and research methods. And it's really important to continue to navigate those and make sure that we're addressing the needs of the different fields simultaneously and effectively. And I'm at the end of my time, so I want to briefly acknowledge the research team. Wouldn't be possible to do any of this without all of them. Dr. Jillian Hayes at UC Irvine, Dr. Sabrina Shuck at UC Irvine, Dr. Franceli Cibrian at Chapman University, one of our key community partners, the Craig School in Irvine, California, and many students and postdoctoral fellows, of whom a few are listed here. We're very grateful to all of them for their efforts to make this project what it is. And I'll end with a slide with my contact information. I'm happy to respond to any questions or requests for further information. Thank you very much.
Dr. Lakes, as a reminder, we'll be taking questions after all presentations, so please submit any questions you have using the Q&A panel. Let's move on to our second webinar presentation, which is being led by David Gustafson. David directs the University of Wisconsin-Madison's Center for Health Enhancement Systems Studies. His research interests focus on developing systems engineering tools to support individual and organizational improvement in addiction, cancer, and aging. His work with the Network for the Improvement of Addiction Treatment is included in over 3,500 addiction treatment agencies. David's individual change research develops and tests computer systems to help people deal with serious conditions. The program, called CHESS, has applications in aging, cancer, HIV, addiction, and asthma. David and his colleagues have produced models to predict and explain implementation, sustainability, and measure quality of care. He has authored over 330 reviewed publications, including 9 books, and was co-chair of the Federal Science Panel on Interactive Communications in Health. And now allow me to turn the control over to David.
Thank you very much. I appreciate the opportunity to present to you guys, and I hope you find it useful. I'm representing a team of people that have played a big role in this thing, and so as I like to say, I've never done anything by myself except go to the bathroom, and so I really have met a great team of people that I'm privileged to be working with. It's part of the Center for Health Enhancement Systems Studies, where we have about 50 clinicians and scientists working together to try to make a difference in the health of people. Our work in aging started with a grant that was funded by AHRQ several years ago, where we went into 3 areas of Wisconsin: urban Milwaukee, a suburban community, and a rural community. And using community-based participatory research, we interviewed about 200 older adults to better understand not only their needs, but also the assets that they had that could be helpful in making their lives sustainable and better. As we carried out these interviews, we learned that our customers and clinicians thought very differently about the situation. Our customers thought that they were really struggling with isolation and loneliness, with lack of community opportunities, and with transportation problems that interfered with their ability to get to where they wanted to get. On the other hand, clinicians thought that the big issues were falls and dementia and behavioral challenges and medication errors and so on. And of course, all are right. These are all problems that the elderly people are facing, but we wanted to really focus as much as we could on the views of the elderly people themselves, and our goal then became one of improving quality of life. As we saw it, quality of life involved 3 things. One was improving coping competence, giving them the skills and tools to make it through their challenges. Secondly, giving them a way of communicating with older adults who are going through the same kind of things they're going through. And then the third thing was to put together a way of continuing to motivate them to keep on keeping on in a time that can be difficult for people of that age. We carried out a randomized trial of a computer system that we developed, the system we referred to as ElderTree. And it had about 15 different services. You can see them listed on the left-hand side of the screen. I'll just mention a very few of them. Each morning you get a different thought for the day. There's a way of tracking your health so you can see what kind of changes are taking place over time and share those changes with clinicians. There's ways of communicating with people via public messages and asking experts questions that they get answers to in 24 hours, and then a series of tools that they might find to be useful, such as relaxation skills. We carried out a randomized trial of about 310 older adults in these 3 communities that I had mentioned before. And we compared people who got Eldertree to people who got an attention control. We monitored the care of these people over a 12-month period, and we found that if a person
This is a
was
reminder. Stand up.
and we found that the system had pretty big impacts once a person was the type of person who spent a fair amount of time with primary care visits in their community. So we found that for people who had visited the primary care office at least 3 times during the previous year, that their mental health quality of life, their depression, and feelings of social support all improved pretty strongly. You can see the p-values there. And so the bottom line of this study was the more chronic conditions that patients had, the more effective we were in helping them deal with those situations. But we saw the system, Eldertree, that we had developed as one that wasn't to solve a single problem, but one that was to maintain quality of life over a long period of time. And that meant that we didn't want to be losing people over time. And while a 25% loss over 12 months is not much for most health apps, we felt it was too much. And so we looked at what might be going on. Why are we losing these people? And there were certain technologies that really seemed to get in the way of things. One was that it required that laptops required that people type, and that can be hard for older adults with tremors. It also required that you remembered a password to get in, and there were other limitations that are presented by laptops that we felt might be interfering with retention of people in the system. So we thought, okay, well, what about voice activation? What about a system that you controlled by just talking to it? And so we developed a system built around an Amazon system that I won't speak out loud because it's going to start yelling to me, but Alexa, and it had basically the same services that the laptop version had, but the smart device, you just controlled it differently. You talked to it rather than typing into it, and we felt that there might be some additional benefits to that particular system. And so we developed and then are in the process of carrying out a randomized trial. We don't have the results of that randomized trial yet, but I can talk to you about some of the things that we have learned along the way. So what have we got? Well, Eldertree is is the system we're working on. It's an electronic health intervention with voice-controlled technology that hopefully can improve the quality of life of people. And the kind of issues that we were searching for, bottom line was what's the effect on quality of life, and is it better than the laptop? But what improves? For whom is it most effective? How does it affect people with physical and mental limitations? And which is more attractive and convenient? Things of those kind of things we were looking at. If you look at the laptop version, one of the things that you'll notice is that we tried to make it incredibly simple to use, and so across this is almost the home screen. There is a first screen that comes up, but after that, the main screen for the system looks like this, and you see across the top 6 different sets of services that people might want to engage in on Eldertree. The little red things indicate that there's new information since they last came on. And then down below are some examples of what happened if you press chronic pain as being the focus of your interest. And you'll see that we have a lot of different kind of resources and activities and things like that. A lot of them we've gone to more video kinds of work than through presenting information directly. The screen size for the smart display is small. It's only 8 inches. But surprisingly, that's not as much of a challenge as I personally was worried about when we got started on this. And so this is one of the early screens in the system. On the right-hand side, you see different kinds of services that you can get engaged in. The left-hand side changes each day, and it's just the kind of services that we would like to feature and call out for people to be able to use. But you could just say to it, hey, elder tree, let's move. And it would move you over to the set of elder tree services. So what have we learned? Well, one of the big things that we've learned is, boy, it is not easy to create a smart display system. It was a lot harder than we had ever expected. We had people from computer science, from communication sciences, all sorts of different groups working on this thing to make it come together. And we found also that there are things that work well on the laptop that just don't work on a smart device. The main ones are the ones that require dictation. You know, discussion groups are the thing that was sort of the key glue that held everybody together, that kept people coming back. You can't do a discussion group very well on a smart display because when you dictate it, you only have a short period of time to talk to the machine. It's very hard to edit what you put in and things like that. And so the discussion group really became inoperable when we moved to a smart display. The screen size was not nearly as much of a problem as we had anticipated, but the smart display is really a very different environment than a laptop. And by having to work on it, the nice thing was that we learned a lot that would benefit both systems. We encountered some problems that I wanted to share with you. One of them I hope you don't come in contact with, and that is we had chosen Google Nest Hub Max as our device. And we did our programming, got the thing up and operating really well. It was operating very smoothly. And then Google said, guess what? We've decided we're no longer going to support the back-end programming. You're going to need to be able to use this system. And so for all of you out there that are doing work with those features, including us, we're stopping in 6 months, just to let you know. And so we were really stuck. It's a business. I sort of understand where they're coming from, but it certainly didn't make things easy for us. So we had to start all over. We had to program everything from start. We had to find a new device, and we chose the Amazon device. And we had to reprogram everything and develop a new recruiting class. And bottom line is, I'm glad we did, because we were able to, I think, make some pretty big advances. One of the things that we had to do, as I mentioned, was to just drop the whole idea of asynchronous discussion groups, and we had to replace it with something else. We went to a Zoom-like kind of feature, which is that we bring together people once a week to talk about how things are going in their lives and to talk about a specific topic area. And we have about around 40 to 50 people participating each week, and we've found that to be a very effective system. And I'd like to sort of talk about what that system looks like. It's not your normal Zoom kind of operation. It's a much more choreographed operation than that. we have a 1 hour meeting each week. As a matter of fact, it's going on right now as I speak. And we spend about 5 minutes just welcoming people and getting them in. Then the next 20 minutes we spend letting people individually mention very briefly something positive or something negative that has happened to them over the week. We then spend some time working on a topic that we had chosen for the week. It might be something relatively concise, such as breathing exercises, or it might be on a topic like death and dying. And we spend 10 minutes sort of summarizing the literature and the research that has gone on in this field and what it's teaching us. And then we have 20 minutes of facilitated discussion where I just facilitate a conversation between the people out there. They ask questions, I ask questions, that kind of stuff. And then we end the hour-long session with a 5-minute exercise that is aimed at relaxing them and a yoga kind of thing. But it also turns out to be a great way of continuing to teach them on how to use the system, because we say, okay, in order to get to this exercise video, what you have to do is go over here, see these buttons, you press this button here, and it sort of reminds them of how to use the system. And then 3 days later, we'll send out a summary of what's happened. So it's a highly choreographed session that people seem to use. Our elder tree system is heavily built on videos, and we have about 100 different videos of things like strength exercises, and we've developed arrangements with various kinds of experts in doing different kinds of, in this case, strength building exercises and things like that. So people can choose something that is a 5-minute exercise or an hour-long exercise that they can go into depending upon their interest. When we get in there, we have to get them to really adhere to a certain set of rules of the road, like sharing just enough or leaving politics and religion at the door. And so what have we learned? Well, one of the things we've learned is don't believe the hype. The smart displays are smooth. They have enormous potential, but they're sold as if they do things a lot more easily and directly than they really do. You have to use specific words. It still does not understand the accent that my main multiple PI, Louise Morris, has. And so she can't make the darn thing work. And you can't use asynchronous discussion groups and that kind of stuff. So it's not as easy as it may sound. But we found that all these people all our participants have never met in person. They found the meetups were the most impactful part of our whole study. We have a lot of content built into the system, but nothing comes close to meeting their needs as much as the meetups do. And so, you can see a couple of the quotes here. The bottom one I'll read. Whatever condition you're in, it gives a way to socialize. It was so nice to see other faces. And so it turned out to be very easy. We had to build in some very simple and easy use to make the system work. A hand-raising function to show that you want to be able to speak. Breakout groups, so we could take those 50 people a week that we have and break them into subgroups for the time when they talk about what's gone well and what's gone poorly. And again, a lot of very positive comments about that. But when the study came to the end, one of the downsides we found is we appeared to be so successful that the thought of the loss of this system was sort of ripping people apart. There was a lot of crying and sobbing, believe it or not, on the screen, a lot of anxiety. And so we had to ask ourselves, how we can't just leave these people alone. How are we going to sustain this service over time? And so we had to put together a mechanism that would allow them to continue to run this service on their own without us getting involved. So we created an alumni site that people could use to really make this system work on their own. And this alumni site sort of taught them, carried them through on doing it. Bottom line is smart devices have a lot of potential, but it takes a lot of work to make them work as well as you'd like. But now Alexa is my preferred device. I use it over 3 times a week myself, and it's really become a useful device. And so thank you for listening to me, and I'll look forward to your questions later on.
Thank you, David. Please feel free to submit any questions you have using the Q&A panel at this time. Next slide. Moving on to our final presentation of this webinar, which is being led by Dr. Sunit Jariwala. Sunit is a practicing allergy and immunology clinician, professor of medicine, director of clinical and research innovation, and medical director of digital transformation at Montefiore Einstein in the Bronx, New York City. He serves as the director of allergy immunology research and created several patient-facing mobile apps which deliver personalized asthma and education to both children and adults. To train the next generation of clinical innovators, he created the Montefiore Einstein Innovation Biodesign Training Program, which launched in July 2020. This program is one of 6 in the U.S. and the first to focus on chronic conditions and health disparities. Sunit is a board-certified clinical informaticist through the American Board of Preventative Medicine. He currently serves as the Secretary of Health, Equity, and Technology and Quality Interest section of the American Academy of Allergy, Asthma, and Immunology. And now I would like to turn control over to Sunit.
Thank you so much, Sheena. We appreciate it. And thanks to my wonderful panelists for their wonderful presentations. We appreciate that as well. So a lot of what I do is innovation biodesign. And 2011, I just finished fellowship. We started the Montefiore Asthma Center. And at that point, we're very lucky to have a health educator on our team and would really prevent patients from going to the ER. And really addressing the asthma epidemic in the Bronx, which as we see here, the Bronx is always at the top in terms of asthma morbidity, 3 times the state average, regardless of age groups, as well as a lot of preventable deaths as well. And, we just have to do more. So again, back then, the Montefiore Asthma Center model, we had, as we see on the left side of the screen, myself, a pulmonologist, as well as Damaris, our PA on the team, who's a health educator. And at that point, the question was how to take Damaris's amazing guideline-based work to other settings. I worked at a North Central Bronx, right down the hall from Montefiore, a few steps away, and we had one health educator on the whole floor. So at that point, we're still in the days of these plastic models, and the question was how to scale Damaris's work to the primary care setting. At that point as well, there were a lot of key limitations. So it was a time just when apps weren't potentially really mainstream, but back then it was 50-50. So you download an app on the app stores in the asthma space, and just half would deliver guideline-based information. A lot of apps back then weren't weren't engaging and really lacked the behavior change techniques. And also less than 1% of apps then were clinically validated. So there are just a few. User attrition, so patients might download an app and forget all about it and just never reap the full benefits. And also the lack of a usability and a user-centered design, as well as other key limitations such as data privacy, security as well. Back then, the main question was, can our disadvantaged Bronx patients with potentially low health literacy access these apps? So we did a survey before we started our app development, and we asked the simple question, do you have smartphone access and internet access at home? and internet access was about 95% across all age groups. As we see here, most patients did have a smartphone access as well. So again, less than 60 years old, almost universally. But then above 60, then you saw the fall off. But the key take home was that apps were accessible by many, many patients. So with this in mind, we developed the Asmix mobile platform, which back then it was just an initial attempt to take our asthma center model to other settings and scale these efforts as well. And some of the key functionality, so we have tailored push notifications, goal setting, patient and provider portals, as well as asthma education that's guideline-based, patient-reported outcomes, and by far the hardest journey, but the most rewarding EHR integration. So since then, we've developed nine more apps throughout our health system, and I lead an innovation biodesign training program. So we've developed apps across chronic conditions, across settings, the ER setting, as well as the surgical setting, and just a few lessons learned. So we address a pain point. As the saying goes, you need to either have the problem or understand it very well. And then the KISS and world of MVPs. So KISS is simply keep it simple, silly, and MVP is minimum viable product with rapid iteration. One of our main lessons learned was that we waited just way too long, I think 3-4 years to launch the first version, whereas our approach now is build the prototype and implement it, and then just get feedback and keep iterating. Team science. So as we say, teamwork makes the dream work. So it's extremely important. Initially, it's just a few of us, but now many content experts, behavioral scientists, psychologists, UI, UX, graphic designers. We have software programmers, administrative, executive champions. So it's been a fun ride. And again, just never too early to launch to get feedback. And here was our MVP, our prototype back then. It was just a simple PowerPoint slide. So we had 10 chapters back then, and it was simply what Damaris would teach in the clinical setting. And here, as we see, just a very simple algorithm. Back then known as the Asthma Educator. And again, just a prototype. So just very, very simple, a start button, and the app was for a tablet. And there was a build file, and here's our initial website. So our journey, I can't believe it. So it's been 10 years now. So first the proof of concept and launch. So we built the prototype. It was the first app ever built out of our health system. So a lot of key players, a lot of lessons learned. And at that point, we had a build file and then had the app launch in the iOS and Android stores. And throughout the whole process, the patient perspective is at the center of everything. So we had patient provider feedback sessions before the app was developed. And then we did a small pilot. And then eventually we tested for patient satisfaction, clinical outcomes, as well as patient report outcomes. And more recently, over the past 5 years, RCTs, adults and pediatrics, and EHR integration throughout the journey, and now the world of biomarkers. All of it is user-centered design, which determines how patients might feel as if they're part of the process, as well as multiple stakeholders, clinicians, and again, the team science approach. So throughout the journey, we've done pre-development focus groups, as well as design sessions. And then once the app has been developed, we've done field testing with formative and summative evaluation, as well as exit interviews. And throughout this whole process, we have a quantitative as well as quantitative picture, so qualitative and quantitative. And we have app usage analytics data on the back end. So app logins, patient report outcome measures submitted, as well as key features, as we'll see, to gamify the process, leaderboards, virtual trophies, virtual incentives. Our initial approach is keep it very, very simple. So we had this drawing that one of our team members had made back then, just some of the potential asthma triggers. And we had the pollen, we had the cockroaches, the rodents, some of the triggers our patients might experience, the mold spores, and then we eventually built a game out of this in our pediatric app and for the basis of the I-Spy game. We kept it very simple initially. So what we call UI UX, how users might hold on to the app and really use it day to day and just engage with it. Our initial version on the left side was no more than a homemade video at the asthma center. And then the center, we had a voice recognition, which at that point, 10 years ago, patients just didn't like, a lot of difficulties there. So we eventually took it out based on feedback. And then on the right side, we have the updated UI UX. So it's a very clean interface, and we've adapted this throughout the rest of our apps as well. Our platform is adaptive as well. So a lot of the inputs, a lot of the data collected feeds back into the algorithms and deploys the content. For example, our goal is always to collect patient-reported outcomes. We've collected these, and based on scores, we would then determine threshold numbers and if patients, if they had suboptimal scores, be redirected back to the app educational content. Whereas if they had very nice scores, then would go to other app chapters as well. And again, we gamify this whole process to help patients engage with the app. So a few words on patient-reported outcomes. So why are these important? So first off, they assess patient symptoms and quality of life concerns. Also enable shared decision-making. Also help to assess treatment adherence. And these mobile health tools can encourage the collection and use of patient-reported outcomes. Our approach to collecting PROs has been, again, user-centered app design with patients, healthcare providers, and embedding patient-reported outcomes within the mobile intervention. So there are different parts of it. For example, we'd have a upfront intake screen, as well as tailored push notifications, as well as monthly check-in notifications or notifications to help patients engage. We'd have emojis, and if patients submitted a PRO, then they would see coins flashing on the screen and just rise up the leaderboard. And especially in the telehealth era, so there's great value for patient-reported outcome collection outside the traditional clinic setting. For example, I'm an asthma specialist, and we ask patients about how many flights of stairs they can go up. Otherwise, how often they've been in the ER. So outcomes that are really important to patients. And app EHR integration, which the value here is the patient-reported outcomes are collected at the point of care, which is just very important for the clinicians and the care team. We've also gamified the entire process. So as we see here, this is our pediatric app, and we have an I Spy game. We have a few other games as well as animated videos, which we've created in-house. And with these, the patients answer very quick quizzes, and these enable to enable patients to receive points and coins and defeat the game. In a more recent project, so we intensified the gamification. So here we're looking at asthma symptom perception, and on the bottom right side you see this infinity runner. But the whole premise of the game is that a lot of patients do have a suboptimal symptom perception. For example, on the anatomy test, they think they're getting 100, but they're really getting a 50. So that means that there's work to do. So throughout the app, we improve symptom perception, incorporate motivational interviewing. And then based on this, patients might receive boosts in the game, or they might receive coins, a head start. And as we see, the perception improves over time. And also asthma control, asthma quality of life improves as well. Some of the motivational features. So we've had trophy rooms based on app logins, based on PROs submitted, as well as PRO ranks, leaderboards, which I was in the top position for a long time, but then patients started to use the app more, and that was it. Medication self-report. So we do have adherence check-ins based on asthma medication, the controllers, and based on these, patients receive hearts, stars, and really enjoy the process. App also enables self-tracking, shared decision-making. And this feature came out of one of the design sessions. So which are the features that patients might want to see? So for at least 3 or 4 of the PROs, patients can track over time. And also we ask about healthcare utilization. So asthma attacks in the past month, steroid courses. Other considerations. So building an app, a lot of it's content generation, but other things to think about. So regulatory, is it a world of enforcement discretion or 510K? Then also security engineering and encryption. For example, encryption at transit, in transit, encryption at rest. So some of the more informatics types of considerations. Data privacy as well, HIPAA, of course, and then funding and sustainability. EHR integration, a lot of lessons learned back then in 2018, so we're ready to integrate. And those are the days of HL7 and middlewares. And now today it's Smart on Fire and common data standards. So again, here was our initial approach. We had a secure app server, and then we got into HL7 interfaces, and then the EHR integration. But now there's other, better, more scalable ways to do it. 21st Century Cures Act, Smart on Fire are just these buzzwords nowadays, but will really change the game in terms of app integrations, interoperability, and it's a very exciting time for all of us. Some of the challenges. So again, integration can be very challenging, very complicated. Just the process, build files, APIs, could be time intensive and expensive. Many, many teams in our Montefiore Information Technology group. The data must fit in with clinician workflows. So you spend a lot of time integrating, but then how are the data used? Are they being used in a timely manner? Are they helping the clinicians? Also, where are the app collected data displayed in the EHR? As we know, many EHRs have on a given screen more than 500 data points. So how do we meaningfully contribute to the care experience? And also regulatory and data privacy. But of course, many opportunities. So patient-generated health data, patient-reported outcomes to the point of care, which otherwise within the clinical setting could be really tough to obtain. Medication use, such as for us, rescue medication use and frequency, which could be a prompt to step up therapy. Healthcare utilization, which at our health system, 15% of patients receive care at other health systems, and otherwise some of these ER visits might be difficult to find. And then this digital care pathway through an EHR app order. So the clinician might order the care pathway, and then the app link is deployed to the patient, and then the patient's entered into a registry, and then closing the feedback loop to the care team as well. So happy to say our asthma app initially in the adult space improved asthma clinical outcomes, such as we see asthma control by 2 months, as well as asthma quality of life by 4 to 6 months. And this was later replicated in adults, in children, across settings as well, primary care setting, as well as the ER setting, as well as reductions in asthma morbidity in adults and children, to reduce hospitalizations, ER visits, and oral steroid courses. What was initially one app in Asthma Excel was later adapted to multiple apps, Diabetes Excel, as we see here. So again, just educational content, goal setting, and otherwise the different chapters as well. As well as overseas, we had developed and validated our app for overseas use, so available in multiple languages, and a lot of it becomes extremely contextual. So it's all about the user feedback, the qualitative analyses, and the themes and topics that are of interest to the patients and doctors. Our extensions of initially one platform, again, just 10 platforms. And once you build these platforms, the first version might take 3 to 4 years to launch, but the latest version during the COVID era, where our health system in the Bronx got hit very hard, we had to develop an app in 10 days and did so. Can't say it enough. Teamwork makes the dream work. So our amazing team of programmers, usability testing experts, UI, UX, IT security, as well as study coordinators, statisticians, behavioral scientists, animation studio, and our advisors across the institution and externally. So our current work, we're working on voice biomarkers, as well as social and environmental stressors, for example, social determinants of health, lifestyle biomarkers such as step counts and other passively collected data, laboratory biomarkers, so digital phenotyping, for example, in the asthma space, serum total IgE levels, and app usage patterns, and also to mention health literacy, so tailoring the app based on a health literacy status and digital health literacy. So we hope that the impact can be by implementing user-centered design strategies involving patients, healthcare providers, the whole health system, multi-stakeholders, Asthma Excel and other asthma mobile health interventions can improve clinical outcomes and reduce health disparities. And just to summarize, asthma mobile apps must be guideline-based, user-centered, and validated, and represent wonderful opportunities for personalized medicine. And again, teamwork makes the dream work. And here's my contact information, so please feel free to reach out anytime. Thank you so much. Really appreciate it.
Thank you, Sunit. And thank you again to all of our presenters for their very informative presentations. As a reminder, please submit any questions you have for any of our presenters using the Q&A panel. This concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type them into the Q&A section of the WebEx portal. Although we might not be able to get to them all today, we will provide responses to all questions in writing. You will receive an email once these responses are available. Go ahead and start with Sunit then, since I see you up. So we have a question for you. Can you please speak about the implementation of voice biomarkers within the Asthma Excel mobile platform?
Sure. Thank you for that great question. Really appreciate it. And our initial approach was a lot of the active inputs, for example, surveys, and could be tedious for patients. But now we do have vocal biomarkers, which are machine learning and artificial intelligence based, which a 6-second voice utterance, such as just saying father for 6 seconds, could be linked to asthma control. And these have been clinically validated, and just making it really easy for the patients to submit voice samples and engage with the platform and self-manage their conditions.
Dr. Gustafson, we have a question for you. What are the benefits of laptops versus smart displays?
Well, some of the benefits are sort of surprising. We had thought that the smart display would be more mobile than the laptop. It turns out that the laptops are more mobile. You can carry them around and move them. The smart displays tend to be a little bit heavier and a little bit more cumbersome. The laptops, I think, benefit most from the ability to speak to it. But the downside is that when you do speak to it, sometimes the system takes a while to respond. And so you have to be patient with the systems. They don't work as smoothly and effortlessly as you might think. But they seem to feel less cluttered and easier to manage than the laptops. So those are some of the reactions.
Thank you, Dr. Gustafson. It looks like Dr. Lakes might not be on yet, so we will go ahead and ask Dr. Jariwala another question. How might social determinants of health be incorporated within the Asthma Excel mobile platform?
Yeah, great question. It's very relevant to our patient population in the Bronx. So we incorporate social determinants within several aspects of the app. For example, with the uptake, upfront screening, with patients list their concerns, and based on these responses, then they receive tailored notifications. And after that, then we do have that warm handoff to community health workers and a list of resources that are geographically organized.
Dr. Gustafson, what are meetups and how do they differ from asynchronous discussion groups?
Well, I think the key way in which they differ is, of course, one is asynchronous, which means you can leave a message for somebody, but there isn't an immediate response. You have to wait until somebody's there. And ideally, it would be nice if somebody was looking at the screen at the same time that you were looking at it. But in reality, that's not typically the case. And so you may have to wait for hours to get a response back. And sometimes you even forget why you asked the question in the first place. Whereas meetups, you are able to ask the question immediately and get a response. That can make them much more effective as a communication vehicle. And it has really served as a way of pulling everybody together. It's the glue that holds the system together.
And it looks like there's a follow-up question that might be related. How many elders are in the meetups?
The maximum we're running right now, we typically run around 50 older adults at any one time when we carry them out. And then we place them into subgroups of around 15 elderly people per subgroup during the first part of the study, where we talk about how things are going with them, what positive things have happened to them in the last week, what negative kind of things. And we go through those things in a subgroup of around 15 people each. And then we come together for the lecture and for the general discussion. And so you're back up to around 50 people per session.
Sunit, how can clinical personnel become more involved in app development and implementation initiatives? Does one require a technical background?
Yeah, great question. So, here it's all about the multi-stakeholders weighing into every part of the process, even before development. So you have the key feedback, the key pain points, and potential champions for adoption later. And then once you develop the app, then even quarterly feedback sessions and just involving what we call the COF model. So it's a clinical, operational, financial, and tech. And you also the legal, just to make sure that the part is data privacy is optimized as well. And of course, the patients are so important. And in terms of tech background, so none whatsoever. I just fell into informatics. I'm a clinician at heart. And it's all about leveraging tech to solve unique patient pain points. So just helping our patients out.
Thanks, Sunit. There's a question for all panelists, so I will let either David or Sunit answer this, or both. What advice do you have for teams using user-centered design methods in a medical school context? For example, how do you involve user-centered design experts on their team? And sorry, I just lost the question.
Primary academic home.
Thank you, Amal.
Well, I can start, I guess. Our university is housed in one central campus, and so we've got a large computer science program. The computer science program has a usability design lab, and so we have worked with them as we created this smart speaker, smart screen device, and had graduate students working from there. Our own team has a group of around 10 different programmers and designers that work on it. And so they work closely with the group. And then, of course, as Sunit mentioned, I mean, it's really important to get the users involved in the design process. And so we start out with a small team of about 8 potential users that we use paper prototypes to show them the stuff, and then the users give us feedback, and then we become more and more sophisticated over time and eventually wind up using pilot tests that allow us to test the operating system. And so it's really a combination of the eventual users and people from the computer science background and our folks. And when we've finally installed the technology, we do not use experts in computers at all. We use people with no expertise in that area, so they can ask dumb questions and behave more like human beings than computer scientists, and that's extremely important.
Thank you, David. Kimberly, we had some questions come in for you. What are the ages of children who have participated in co-design workshops, and was it difficult to engage them?
We have worked with children as young as 10 years of age and up through 14, 15. Our focus has been middle school. We find that they're actually very eager to engage in the co-design and to share their ideas and their preferences. So in terms of the co-design, I think it's been a really valuable process for them. They like having a voice and like having some input into how things get applied and how their treatment goals and their preferences might be integrated into the system.
And what kind of feedback do children provide during co-design, and how did that differ from what was provided by caregivers?
I think, one of the interesting discussions was the value of using a smartwatch versus a smartphone application for the youth. And, there's advantages and disadvantages to each. And for this particular age group, the smartwatch was especially valuable because it's right there. They are able to wear it. They don't have to remember to take it with them. And also in school settings and in some other settings, they may not be allowed to have a smartphone available or near them. So it had that benefit. It also had the benefit of being very discreet, and even, in the design workshops, they talk about recommendations for how to make it even more discreet. So for example, there was a preference for at certain times, the notifications could maybe just be like a rumble in the smartwatch rather than something visual that might pop up that someone else might see. In terms of, other differences between caregivers and children, their preferences for how they would visualize progress over time and what would be meaningful to them and how they would interpret that was very different. As well as, their concerns about privacy, with caregivers often wanting to have as much access to as much data as possible, and for children sometimes wanting to not have their parents be able to see everything, to be able to have even some of their mood reflection or some of their other, self-regulation work not be as visible to others, and to have more privacy over that. Those are, I think, a few of the both with caregivers.
Thank you, Kimberly. Sunit, how do you account for the different age cohorts when developing the apps? For example, a 75-year-old asthma patient may have a different approach to smartphone tools versus a 35-year-old patient.
So I think a lot of it comes down to user-centered design. For example, the upfront development focus groups, pre-development focus groups for overall feasibility. That was one of the first questions that we asked back in 2013. Just, do you have access to a smartphone, and would you ever use such an app, and then which features? So these focus group sessions should definitely be well represented, generalizable. I think large enough but not too large, and a series of these sessions until we reach concept saturation, thematic saturation, and themes emerge from different stakeholders.
We have a question for all panelists, so I'll open this one up. From an equity perspective, how have you engaged or accounted for people who don't own a phone that can download an app, or who don't have reliable internet at home, etc.? Many solutions today would not work for these people.
And who was that question aimed at?
It was just open to all the panelists.
Well, it's becoming less of a problem than it has been over time. You just don't run into many people that don't have access to these kinds of technologies. With the infrastructure funding that recently came out of Congress about 2 years ago, there was a big buildup in the amount of access to the internet out in rural areas, which has helped an awful lot. And that's and we do have a pot of money in our research funds that pay for the cost of internet and for the cost of smartphones, but it's only rarely used these days. It's much less of a problem than what we might think.
I guess I could just echo that as well. I think we were anticipating that it could be a problem, and so we budgeted for data plans. We have some older model refurbished phones that we had available, to provide, and have rarely had to do that.
I would echo that as well. We did a study with the Max Wise cohort, so a lot of patients in the shelter system in the Bronx, and we offered free phones to these patients, but many times just were not used. Just wasn't such a problem.
Here's another question open to all panelists. Are any of you familiar with the Apple Research Suite? And if so, do you recommend using the Research Suite for initial app development?
We did look into Apple Research Kit maybe 8-9 years ago, and it was a very nice platform, I think, for that prototype. I think our issue there was kind of the customized features. So just our vision, just wasn't aligned, but it's a great resource.
Also, for all panelists, did you have to get IRB approval for your studies?
Sure.
Yes.
Thank you, everyone. Next slide, please. We have reached the end of our time for this webinar. Thank you for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will select today's webinar, which will be indicated by date and title, to claim your credits. You will have 14 days to claim your continuing education credits. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete this survey to share your feedback with us. Thank you.